So, we spent the whole of today looking at the technical aspects of how we fix these fractures. And that's probably our job, but really there's a scale of problem emerging, certainly in the UK and throughout the world, that we are going to get overwhelmed with this type of fracture, the elderly frail hip fracture. And we are only one part in how we can treat them. And can we do better? And I'll share with you really ways that we can perhaps do better in managing these patients, and then show that if you do that and you measure what you're doing, you may just improve their outcomes. So, current UK, 70,000 a year, elderly hip fractures. The socio-economic cost to our country is £2 billion a year to look after these patients. So there's a lot of money out there that's being spent on these people, so maybe if we redirect that money in a better way, we'll reduce the overall cost. And that figure is exponentially rising. It's predicted that 50% of the people alive today will live to beyond 100. And in the UK, 70,000 a year, 73% are female, 70% are over 80, 75% have ASA grades, that's the anaesthetic risk of 3 or higher, which means they have significant systemic disease. The average number of comorbidities for these patients is 4. So as orthopaedic surgeons, we are probably not best to start to understand these things. Some of us will recognise the words, but may not actually know what to do with it. And they're all, this is the average day's take for us, 5 elderly hip fractures, and every one of them will have at least 3 of these things. And our perception as orthopaedic surgeons is not, amongst our colleagues, is not great. Maybe true. That's running a bit fast. Don't know what you're doing to it there. You've just run my whole thing. Okay, well, we'll move on. So they are multifactorial problems, one of which is the hip fracture. And because they're multifactorial, they need multidisciplinary approaches. And they require teamwork, and we're now recognising they require formal geriatrician medical input. Now, multidisciplinary working is quite important, and the benefits are it gives you better communication and you can share information. How you do it, you can be flexible in how you collaborate, and I'll talk about models of care. And it gives a collective responsibility for the care and the outcomes, and not just what we're interested in is the fracture and making sure we fix the fracture well. So traditional orthopaedic care is probably what most of us do. We take the patients under our care, and we have a variable geriatric input, either it's usually consultative. We call them up if there's a patient with certain problems. If you're lucky, they'll do regular ward rounds, and if you're really lucky, they'll start to do multidisciplinary ward rounds and try and time it with you. But in a busy trauma unit, it doesn't always work, and often you don't always get the right deal, and it's very much ad hoc. But that's traditionally what happens, certainly in the UK, or until recently. Another model would be to actually have a geriatric ortho rehab unit, which we again admit the patients, we're responsible for the perioperative management, and then they're very early discharged to a geriatric rehab unit, which economically has proved not to be that good. It does rely on then the orthopaedic surgeon having to go and visit that unit, and we've proved certainly locally that doesn't happen very often. It's always given to the most junior consultant who drops it within 6 months because it's a bit tedious to have to go to another hospital or to another ward and just do a ward round. So but that's one unit, one model, and in some places it works, but the studies show that the cost of employing a whole new ward with a whole new staff for these patients is not proving better outcomes. And perhaps the best model is combined orthogeriatric care, where you basically have at least one of your wards, which is almost a specialised orthogeriatric ward, remembering that 73% of these are female, so you can actually allocate one ward to the female hip fractures. And that starts you bringing them under combined care, so that you have an orthogeriatric consultant who is on that ward. At least half of his time is dedicated to that ward. And it starts you going down the line of developing what we call a hip fracture service. And therefore they get orthogeriatric pre-op assessment and post-op care, and so all those medical conditions that leave us a little bit confused, they look after, and they start to optimize the patient for us. The advantages are they definitely get improved medical care because they're not getting orthopedic residents trying to remember their medicine from their medical school days. They get senior input into medical complications, such as all the problems that we're going to face, nutrition, whether we resuscitate, there are palliative care issues. Also, the key is they optimally schedule surgery because they can tell you when that patient is optimally ready for surgery, and they know that is the pressing position to try and get the patient fit as soon as possible. Much better communication with patients and relatives, which becomes very important when you start to plan discharge. And you certainly get earlier rehab, and they start the discharge planning from the day they come in. So that's ideal, and it's something we perhaps should strive towards. There's lots of reasons why we don't change. We're a pretty resistant bunch to change. And a lot of them are quoted, well, they won't fund it, and it needs more money, we don't have the space or the equipment for that. And we look at reasons why, yeah, well, we'll just carry on and do the best we can. So in the UK, that was certainly the position at least 5 years ago. The way to change things, if you believe that that's a good thing for your patients and for your hip fracture service, is to gather some facts, and then the second thing is to give them some money. Make it's financially incentivized to make care improve. So the way we gathered facts is that you set your standards, and in 2007 this document came out from the British Orthopaedic Association and the British Geriatric Society, which basically set out some professional standards of care about fragility fractures. It was a really well researched, we call it the Blue Book. It looks at the problems that we face, the way we can start to improve it. And it came out with audit standards, which basically you could then start measuring. You can only measure standards if you collect the data. So at the same time, a national hip fracture database was set up. So we took all the existing local hip data. We already had a hip fracture audit service going. Started to combine them and recruited nationally in England, and so that we currently have 197 hospitals registered who have to submit all the data. So it's up to now 5,000 patients a month. There are now, that's gone up now, there's 180,000 patients on the database, and it's only been going 3 years now. So the data is being collected, and they collect everything. They collect all the facts about the patient, right from where they come from, into comorbidities, what their fracture pattern is, how the fracture was treated, how long they stay in hospital, whether they received certain standards of care. And that's all produced, and we get a national hip fracture database report every year, where you can find out your hospital, you can find out how you're doing, how much data you've submitted, and where you stand in the pecking order. Now, the 6 key standards that they measure are the admissions protocol. In other words, getting that patient onto the orthogeriatric floor or the ward within 4 hours of them hitting the hospital. They must receive joint orthogeriatric care, so they must be assessed by an orthogeriatrician. Their surgery should now be done within 36 hours if they are medically fit. They must have had a rehab assessment, an osteoporosis assessment, and a falls assessment. Sounds a lot. This is why you need co-managed care. You can't possibly provide that as an orthopaedic surgeon, but we have a multidisciplinary team that provides all that. Now then, the reason you'll get people to do it is the government have introduced a best practice tariff, so that if you meet the 6 standards, and the database can prove that, because you'll have had to submit the data to that, and they'll go back to the database, you then have decided you have been deemed to have achieved best practice tariff. And if you have that, for every patient that you do in the first year of entering patients, you get an uplift of £440 per patient. back to the hospital. If you continue to do well in submitting your data in the second year, you get an uplift of £880, which in our hospital means that our trust hospital get an extra £730,000, which allows us to reinvest it into a hip fracture service. And in the third year, we're earning our hospital £1.5 million if we follow best practice. So all of a sudden, there's a good reason to try and do it. Now then, the question is, does that make any difference? Well, we can look back over the last 3 years and we can see that this is all hospitals. Everyone is certainly starting to do it, so they're all getting Falls assessment, they're all getting surgery earlier, they're getting a marked increase in assessment by a geriatrician, and for the first time, remember this is a patient population who have a 30-day mortality of 10%, which are probably the sickest patients in the hospital. If you lost 10% of your patients within 30 days, the people would start asking questions. For the first time ever, we've shown over 3 years on a national basis, we have reduced from 10% to 8%, which is a 20% reduction in mortality, which is the first time that's ever been shown in this patient population. So maybe co-managed care as part of a hip fracture service is going to be helpful for our patients, and maybe we can improve outcome. You need to collect figures and you need to incentivize people to start entering the data and to following the standards. So in summary, the incidence of elderly frail hip fractures is ever increasing and it's not going to go away. We are a level 1 trauma centre in my hospital, as well as serving a base population of 800,000 people. So we have to treat both, and we are being overwhelmed with fragility fractures. So we've had to develop a hip service to keep us afloat. There's no doubt that optimising medical pre-op and post-op care is very important. Co-managed orthogeriatric care is important, improving outcomes. We're beginning to show that as part of a hip fracture service, but it's multidisciplinary. And we are just part of the team. They are our patients, but we share them. And if we share them, we might improve them. Thank you very much.